Hi, thanks for watching episode number 92 of the Doctor Podcast Sykert File Show. And I'm Dr. Robert Sykert, your host. And we'd really appreciate it if you could subscribe and follow Doctor Podcasts. And if you could also like and repost and share this episode with your friends, family, colleagues. I'm sure they'll enjoy it as well and learn a lot today. Today, we're talking about a very important topic, and that is the treatment of cancer with radiation. And today, we're talking about a special topic of treating cancer with proton radiation as opposed to the standard radiation that you've probably heard of for many years or decades. And I'm really happy to have two excellent guests today to discuss proton treatment. And they are two of the world's leading experts in this type of treatment. We have Dr. Charles Simone. Dr. Simone is the Chief Medical Officer of the New York Proton Center here in New York City. He's a board certified radiation oncologist. He is also in the Department of Radiation Oncology at Sloan Kettering Cancer Centers, which is one of top two cancer centers in the USA, if not the world. He's an expert in chest and thoracic radiation and re-radiation, which we'll discuss as well. He's been involved in many government-funded clinical trials about radiation treatment and proton treatment. And he's written about 600 articles on the topic and has given hundreds of lectures on radiation oncology and proton therapy as well. Our other guest is Dr. Haibo Lin. Dr. Lin is the Director of Medical Physics at the New York Proton Center. He has a Ph.D. in solid state physics, a second Ph.D. in optical imaging physics, and a master's degree in medical physics. And we'll find out why that's very important at the Proton Center. He's published many articles on proton therapy and radiation oncology as well. So thank you very much, Dr. Simone, Dr. Lin, for taking time from your busy day of treating patients to appear on the Doctor Podcast program to discuss this very important topic. We really appreciate it. So, Dr. Simone, I want to start with you. Can you tell us how you became interested in radiation oncology and tell us about your education and background in this very important field?
Yeah, of course. And thank you very much for having us. We're excited for the podcast. I was very interested in oncology growing up. I had an oncology household. My father, a medical oncologist and a radiation oncologist, my sister, a radiation oncologist.
Wow.
I was looking for how we can kind of put it all together and what is the best approach for treating patients. And one thing that really appealed to me and from a radiation oncology standpoint was how quickly the literature changes, how fast the technology changes. Both of those were very appealing to me. I knew I wanted to have research be a big focus of my career, and I thought it would be a great opportunity to really try to help advance the field. So got very interested in radiation oncology. Also, nice thing about radiation oncology is many of our treatments are every day, Monday through Friday, for several weeks in a row. And so we're able to form bonds with patients. We see them over time, hopefully in many cases cure them. And so it really was a rewarding field. So got into radiation oncology that way. And then I guess I'll take it a step further how I got into proton therapy.
Yeah.
Uh, Most of my early research in radiation oncology was on how to mitigate toxicities of treatment. We know that radiation oncology is one of the big three pillars of cancer treatment, along with surgery and systemic therapy. But just like those other modalities, it can have significant toxicities to patients. And so I really spent a lot of time figuring out, are there radio protectors that we can use? Are there different techniques that we can use to deliver the radiation? And ultimately, my research came to a different type of modality, proton therapy, that can potentially help protect normal tissues better than traditional radiation can, so it can better preserve patient quality of life during treatment and help to reduce some of those side effects. So that's how I became very interested now, geez, about 15 years ago.
Wow. And interestingly, your family is also very interested in that. There must be a gene for radiation therapy treatment, and we're thankful that you're doing that. So tell us how the standard radiation, which is X-rays and gamma rays, treat cancer or kill cancer cells. How does that work?
Yeah, great question. So the majority of radiation, whether it's the X-ray, photon radiation, or even protons, when it's delivered conventionally every day, Monday through Friday for the several weeks, like I mentioned, essentially we damage the DNA of cancer cells. And when the cancer cells are damaged, they then are not able to divide and they're not able to grow. Ultimately, generally, that damage causes the tumors to die or shrink, and the body can reabsorb and break down those dead necrotic tissues. But double-stranded DNA breaks is the pillar of how radiation works across all modalities. The one kind of caveat or exception I'll say is increasingly our field is delivering what's called stereotactic body radiation therapy, if you may have heard of that. It's delivering very, very high doses of radiation in just a few days. So instead of say a 6-week course of radiation, it may be as quick as one day, but typically 3, 4, or 5 days. In doing so, we deliver such a high dose to such a focused area of tumor, as opposed to just damaging the DNA, we actually completely ablate the tumor. So that causes several other cascade mechanisms of death from the tumor. But in general, it's DNA damage. That's the pillar of radiation.
Right. So the standard types of radiation were X-rays and gamma rays, which are made out of high energy photon particles. How is proton therapy different than that?
Yeah, great question. So about 98% of all the external beam radiation that we deliver for therapeutic treatments for cancer are X-rays or photon radiation. They're delivered through a linear accelerator. The machine fits in a room, kind of the size that you see behind me. Uh, the machine rotates around the patient, delivers the radiation. But as that radiation leaves the head of the treatment room, it keeps going in a straight path. So it enters in the patient, it hits the target, and then it keeps going out the other side of the patient. So it goes through and through the patient. Photons, they're light, non-charged particles, so they'll continue to go until they lose all of their energy. Proton therapy, it's a heavy charged particle, uh, has very different properties. And you'll hear us talk about things like Brad Peak and others later in the podcast. But essentially, the hallmark is that protons can stop, whereas photons can't. So we can actually set the radiation to stop at the depth of the target that we want to treat. So the radiation now comes in, hits the target, and all the radiation gets deposited at the target area. Now no radiation goes beyond that. So what that means for the patient is any normal tissues that are beyond the path of the tumor itself can now be completely spared of radiations. And that's how we think, one, we can have potentially better side effects for some tumors, but also in some cases it can allow us to more fully treat the tumor without having to worry about those side effects that can lead to even better outcomes for some tumors.
So the proton beam basically can be targeted much more accurately and precisely than the standard X-rays. Is that right?
Correct. The field in general, protons and photons, has really had tremendous leaps and bounds over the last 2 decades and really over the last 5 and 6 years. But the hallmark is still the same with regular radiation, as conformal as we can do, and we can modulate the intensity of the radiation across the beam. But in all cases, the radiation is going to continue after it hits the target. So the proton therapy can really just target the tumor itself and protect those normal tissues.
Right. Now, I understand that there are different types of proton therapy as well. And which one do you use at the New York Proton Center?
Yeah, great question. So we use pencil beam scanning or scanning technology for proton therapy. Older, earlier versions of proton therapy used passive scattering or double scattering and then evolved a little bit to uniform scanning. But today, the large majority of treatments are delivered with scanning technology. Really, in the last several years, it's been the exclusive way to deliver radiation with protons in newer centers. Older centers still use passive scattering and double scattering, and certainly a great option. The dose still stops, but with pencil beam scanning and the ability to deliver intensity modulated proton therapy, we can not only benefit from having the dose stop to protect those normal tissues, but we can modulate how the dose comes into the tumor, and we can sculpt the dose around the tumor much better than we could with first generation proton therapy.
So basically, you're using the latest state-of-the-art technology for your proton beams.
Exactly right.
Right. And how many proton radiation centers are there in New York and the USA? I understand there aren't too many.
That's right. We're the only one in the state of New York. Um, there are a total of 49 operational centers in the United States. That number's increased dramatically. I started treating with proton therapy in the 2010, 2011 range. At that time, there were only 5 proton centers in the country.
Wow.
So certainly a lot has changed in the last decade and a half. Every year we seem to be adding 3, 4, 5 proton centers, but still a limited resource. And we're still, for a big populous state like New York, we're the
Yeah,
only proton center here.
the only one. How many, how long have you been open now, the New York Proton Center, and how many patients have you treated approximately in that time period?
We opened in July of 2019. We treated our first patient in August of 2019. And since then, we've treated over 5,500 patients. We actually celebrated both our 5-year anniversary and our 5,000th patient last summer and last fall. So, 2 big milestones for our center. But each year, we're treating on the order of about 1,200 patients now that we've ramped up and gotten over the COVID fiasco
Right.
that happened literally just months after we opened. Obviously, devastating time in New York and everywhere else, but. Now that we are kind of fully operational, we're treating about 1,200 patients a year.
Oh, that's great. So, Dr. Lin, I wanted to ask you some questions as well. How did you become interested in medical physics and radiation oncology? Tell us about your education and background.
Yeah, thank you for having me today.
Pleasure.
Yeah, I was born in China and studied applied physics as a bachelor degree, and then I continue my graduate study in Ph.D. for semiconductor physics. And in my third year of study, I get opportunity to come to the United States. And basically, it's we try to set up a lab and apply the semiconductor devices we made during my PhD for optical imaging purpose. So that's for like cell and like some animal imaging. So that actually lead to my second PhD study in optical imaging. So basically, I have like almost 2 years between these two degrees. And during the second degree for optical imaging, because I don't have much of background for imaging, so I actually take some courses in engineering department for imaging processing. That actually is it's basically taught by some medical physics faculties, and then that's where I learned this program. And then I took quite some of courses there, and then just at the end I just get my PhD and same time get a master degree in medical physics. And after graduated from the school, I actually matched to the residency program at the University of Pennsylvania. And after 2 years residency, I joined the physics group there because they are opening the Proton Center at the UPenn. As Dr. Simon mentioned, that's the fifth Proton Center in the United States. And also, that's where I first met Dr. Simon and worked together for a few years. And after almost 9 years at UPenn, New York actually built the first Proton Center. I got the opportunity to join the group, and then we worked together with Dr. Simon again, and continue the proton journey. And it's really rewarding medical physics field, different to the conventional physics. You feel the value immediately because you are service the patient and you can see the impact.
Right. So, what's the role of the medical physicist at the Proton Center, and why is it critical to provide the best care for patients? What do you do there?
Yeah, for medical physicists, basically we are responsible for radiation safety. That means the safety for patient and safety for all the staff members. We are also responsible for all the quality assurance, the machine. That means as Dr. Simon mentioned, the radiation actually require precision and accuracy. Precision, that means the positioning of the radiation delivery itself need to be like sub-millimeter. Accuracy,
Sub-millimeter. So
yes,
that's
yeah,
very, very precise and accurate.
yes, yes. Accuracy means like, when the physician prescribe a dose level to the tumor and those constraints to critical organs, we won't be dead on. We're talking about the like 1 to 2% of deviations. So those are like, part of quality assurance. Of course, the machine performance is one thing. The other thing is, when we treat the patient, the whole course actually lasts for a few weeks. We need to monitor those patients and make sure any like anatomy changes, any like response to the radiation treatment will cause some deviations of the delivered dose, and we may have to adjust the plan, to adapt the plan to restore the dose and maintain the high quality of treatment. So those are the majority of the work. At the same time, we are participating the development work. That means the new technologies and anything that can associate with the patient care improvement.
Right. So when you treat these patients, they may get some swelling or inflammation or edema, which may shift your target organ just a few millimeters. So you have to readjust it every treatment session, right?
That's correct. So during treatment, we every day we use like X-rays to align the patient, and we also do like a cone beam CT and to get the soft tissue information. If there's a large deviation, like from volumetric point of view, and deviate from the original planning CT, and then we will try to justify the dose. And if the dose deviation is large enough and it causes either like some loss coverage of the target or critical organ dose is too high, we'll try to replan and immediately start to re-optimize the dose to restore the dose to coverage to the target or the dose to critical organs, and then we resume the treatment.
Right. So everything has to be super accurate and precise at every session. Why is it more difficult and expensive to create proton beams than X-rays?
It basically originated from the nature of the high energy proton itself, because in order to treat tumor at a different depths, and it require the proton system has the energy up to 230 to 250 MeV. And different to like photons, you just need a 10 MeV or 18 MeV. So in order to actually just heavy ion particles to like 250 MeV, you need a very complex system like cyclotron or synchrotron. Besides the those complexities, you also need to have very precise transportation of the beam, also the energy selection system, and operation system like service system. All those actually need like thousand parts. That's why besides those, you also need a much larger room. For example, the linear gantry only you can accommodate just one floor, but for proton delivery system, basically need a three storage space to accommodate the gantry rotation. So you can see like the size, the dimension, require actual or additional shielding constructions. That's also additional cost. That's why like the proton system or center itself is really costly.
Right. So this is a huge, massive machine and undertaking.
Yes, yes.
Now,
Well, I'll just add, you can see the building behind Dr. Lin. That whole building is designed just to house proton therapy, and you can see it's 3 stories. As Dr. Lin was implying, the proton machine essentially rotates 1 story above the patient and 1 story below the patient. So it's a 3 story gantry that rotates around the patient. That gantry itself is nearly 300 tons. So a big piece of equipment, a lot of counterbalances, several tons worth to make it work. But that doesn't even make the radiation itself. To make the radiation, as you heard, you need a cyclotron. We accelerate particles 2/3 of the speed of light at -425 degrees Fahrenheit to make proton therapy. So it takes that device to then be siphoned into a treatment room that's 3 stories tall. So a lot more moving parts, a lot more expenses. Even just the cement in the building itself was actually 8 figures of cost for just shielding from radiation.
Wow, that's incredible. Massive machine and massive undertaking. So, Dr. Lin, where do you get the protons from? I remember from physics, protons are at the center of the nucleus of an atom together with neutrons. How do you strip out the proton, and which kind of atom is it coming from?
Yeah, the proton basically come from the hydrogen, and
Hydrogen.
because hydrogen contains proton and electron. So like in most of proton center, the proton source is basically come from the hydrogen gas. It's highly purified hydrogen gas. So the gas is injected into the proton source system, and in that system, it has some like electric field, basically try to ionize the hydrogen gas and convert them into separate them into the protons and electrons. Because of electric field and also the charge particle of protons and electrons, they basically move in a separate way. And then you have another electric field just to pull out the electron and inject them into the cyclotron and start the acceleration process. So yeah, in simple word, just like from the hydrogen gas itself.
Wow, that's incredible. How many protons are generated in a treatment?
Well, that's a good question. So talking about generated in or injected into the cyclotron itself versus the protons actually delivered to the patient, it's actually are totally different. So when we're talking about the protons for a single treatment, basically interact with the tumor or tissue, that's depending on the tumor size, depending on the prescription of the dosage level, and depending on the tumor location, means the depth of the tumor. But typically, it's ranging from a 10 to power of 10 to 10 to power of 11 protons.
Wow,
Yeah, those are
that's a
numbers actually
lot
enter the
of
patient's
protons.
body. Yes, yes. And however, there are a lot of proton actually lost during the transportation. If we are talking about like a low energy, we probably only have less than 1% of proton actually reaching to the patient. There are 99% of proton lost during the transportation process. So that means you have even much higher number of protons injected into the cyclotron, but after the acceleration, it actually get lost during transportation itself.
Wow. And then, as Dr. Simone said, you accelerate these at a fraction of the speed of light and like minus 425 degrees. That's almost as cold as it was in New York City this past weekend. So that's pretty amazing. Now, I know now that protons are actually made out of quarks and that are held together with gluons. Do these protons break apart into the smaller quark components, or they stay intact as single protons?
During proton therapy, they actually stay as a proton. The main reason is in order to break them into quark, you basically need a much higher energy. We are talking about the uh, uh, like a tera mega voltage, but the proton itself is only mega uh, you know
So it's
energy per
magnitudes
unit.
higher energy, so they don't break
Yes.
apart into the individual
Yeah.
components.
Yeah.
Now,
That's correct.
how many medical physicists other than you are at the New York Proton Center to make sure all the equipment is working right and you're delivering the exact correct dosage to the specific submillimeter target? How many other physicists do you work with?
Yeah, in the New York Proton Center, we have additional 11 physicists.
11.
Also, yeah, include a few of planning physicists. Their expertise is on planning. And the most of it is actually covered planning, also the machine support and other things. We also have four physician assistant and help the physicists for quality assurance. And besides, we also have 12 dosimetries, which we typically call them treatment planner. So they actually took the prescription from physician and based on the dose constraint and dose prescribed to the target and use the commercial system to optimize the dose based on the tumor delineated by the physician. So that's also part of the physics team. So that's medical physicists and the medical dosimetrists are the major part of the physics team.
Guys, an incredible operation, numerous highly technical brains working together to make sure patients get the right treatment. Now, Dr. Simone, you mentioned earlier a little bit about how the tumor or cancer is targeted, and you mentioned that you can aim the protons at a specific point and then they don't go beyond that, whereas X-rays just go through the body until they hit the lead liner of the wall. But what about the tissues in front of the target cancer? For example, if you have a lung cancer and you're aiming a proton beam at that lung cancer nodule, you're still going to hit the tissues in front of that lung cancer with the proton beam, no?
Exactly. Very astute question. Um, you know, beam for beam, proton therapy does actually deliver less entrance dose. So essentially, you have a lower dose going into the body, you hit the target, and then all of the radiation gets deposited at the target, and then no radiation beyond. So there can still be sparing with proton therapy to the tissues in front of the target volume. But the biggest difference relating to the question you asked earlier that I didn't go into as much, with passive scattering, with double scattering, essentially 100% of the dose travels along that path of entrance until it gets deposited and then stops. With pencil beam scanning, we really can have low doses going into the normal tissues and then hitting the target and stopping. So we can see less entrance dose. That being said, certainly not zero. Better than we can get with photon therapy, and the biggest benefit of protons is what's after. In your example of lung cancer, yes, we would still go in through the normal lung, but the concern with lung cancer, the large majority, about nearly 85% of all people with diagnosis with lung cancer have lymph nodes that are positive at the time of their diagnosis. If we're targeting lymph nodes in the mediastinum and the hilum, the other side of that is then the heart, the esophagus, the airway, the spinal cord. All of those structures can be dramatically decreased in dose or even completely avoided with proton therapy because while we can't necessarily eliminate the dose going in through the normal lung, we can have the dose stop before we hit those critical central structures.
Sounds amazing. It sounds like there's much less collateral damage to adjacent tissues and organs with the proton beam as opposed to an X-ray beam, right?
Yeah, it really can be. In some tumors, we do very well with traditional radiation, in fact, many of them. And so any benefit with proton therapy would be smaller. But some tumors where we either have high toxicity rates or poor tumor control rates, proton therapy can really be a game changer for many patients.
Right. Now, can all solid cancers be treated with protons, or are there specific types of cancers that do better with proton versus X-ray radiation?
Yeah, great question. In short, yes, any solid tumor that can be treated with photon therapy, we can treat with proton therapy. Now, if we're treating, for instance, an entire brain, the entire brain is going to be treated with protons or photons, so that the benefit would be smaller. But any focal area that we're treating, which is large majority of the patients that we treat, proton therapy can be used. So it can be considered as another type of treatment, just like the photon therapy can for any of those patients.
Right. Now, the most common cancers right now are breast, lung, colon, prostate, basically. Can you treat all four of those with proton therapy?
Yes, we can. The one of those examples that I would say colon cancer, we don't treat a lot with radiation. The standard of care for colon cancer is typically surgery, and then for more advanced cases, also chemotherapy. Only a select number of positive margin patients or node positive patients will get radiation therapy. But if a patient was to get radiation therapy, yes, it can certainly be delivered with protons instead of photons for those patients. Breast cancer is actually one of the two fastest growing indications for proton therapy in the country.
Mm.
Of course, we're seeing a lot of younger node positive women where proton therapy, we send the radiation in, we hit the target, and then all the radiation stops before we deliver that radiation dose to the heart. So we can prevent those late complications for women. So that's a very common indication. Lung cancer, a lot of good data that we can potentially help to reduce toxicities, prevent hospitalizations, and maybe improve outcomes and survival as well. So another good indication of those ones that you mentioned, and prostate as well.
Right. Now, I mentioned earlier briefly about retreatments. Can you tell us why proton beam is exceptionally good for retreating any type of cancer?
Yeah, so many of the patients that we treat with a curative intent, yes. Obviously, radiation is used for palliation or either to mitigate, to help to treat, or to prevent symptoms. But in patients that we're treating with curative intent, um, hopefully we do cure patients, but we certainly don't in all patients. And sometimes the tumor can come back either locally or regionally in the area that already was exposed to radiation. The kind of dirty secret of radiation oncology is we don't always deliver radiation with the knowledge that we're going to cure a patient. A lot of times, unfortunately, we're delivering enough radiation that we hope can cure a patient, but that doesn't cause a significant toxicity for our patients. The normal tissues can be very sensitive. So lung cancer is a great example. The lung can only take so much, the normal lung or the esophagus or the heart. Liver cancer is also very common. If we try to overly aggressively treat the liver tumor, we can cause liver failure for the normal liver. So for those tumors, we need to take a risk-benefit approach and treat the tumor with as much radiation as possible without causing such a horrific side effect or a high risk of a horrific side effect. So that means if we're not always able to give enough dose, the tumor can come back. Historically, it's been very difficult to do anything with more radiation for those cases because the normal tissues may have already been maxed out of how much radiation they could have tolerated. We've already treated them to the safest amount that they could treat.
Right.
So we generally can't deliver radiation a second time around with photon therapy. Of course, there are exceptions, but with proton therapy, we can send the radiation in, we hit the target, and have the radiation stop before it's delivered to any of those normal tissues that may have already had their maximum lifetime amount of radiation exposure. So we're able to, with the radiation planning team and then the physics team that Haibo mentioned, we're able to deliver these radiation plans that can safely retreat the tumor a second or even third time without exposing and overexposing those normal tissues. So re-irradiation is a big part of what all proton centers in the country do. We have actually the highest proportion in the world here at our center. About 42% of all patients that we treat are coming to us after prior radiation. And we're offering them a new chance at cure in many of these cases that they really couldn't have had otherwise.
That's great. Now, does the proton beam come in as like a pencil? Dr. Lin mentioned earlier, and you did as well, or does it come in as a cone, and the tip of the cone is the target cancer?
Yeah, great question. So with regular radiation, you can think of it as a cone or really I would say a flashlight in that the radiation starts out smaller and diverges as it gets closer to the tumor. So even more and more normal tissues are treated. With proton therapy, with pencil beam scanning, it really, you can think of it exactly like a paintbrush or almost a typewriter for those of the audience who's used typewriters in the past. But essentially, you take a mass and you're delivering the radiation kind of line by line. So you're going in a line and you kind of hit the enter key and you go to the next part of the tumor. So we're literally painting with about a 2 millimeter-ish brush all aspects of the tumor in 3 dimensions, really 4 dimensions, because some tumors move with respiration or other effects. So we also take that into account in addition to the regular 3 dimensions of a tumor.
Right. Now, I'm an ophthalmologist, and occasionally, rarely, unfortunately, I see patients with melanoma of the eye, of the choroid, which is the back of the eye. Can you treat choroidal melanomas in the back of the eye with proton therapy?
Yes, actually, ocular treatments are one of the very first indications, actually the first treatments of proton therapy back in the 1950s were for ocular tumors. Uveal melanomas, other ocular tumors are really one of the hallmark early indications when proton therapy was becoming FDA approved back in 1988. It was thought that pediatric patients would have tremendous benefit, ocular patients, and then patients with spinal cord tumors, where we were worried about causing paralysis with the regular radiation that proton therapy could avoid. So it's long been a standard treatment. Certainly, there are a lot of good options, as you know, for ocular tumors. Brachytherapy, another type of radiation, a very focused insertion of radiation is a good option. I will say protons really can distinguish themselves for ocular tumors in two ways. One, for thicker tumors, typically over 8 millimeters, brachytherapy, the tumor coverage generally is not sufficient. And so the tumor control can be better with proton therapy for those thicker tumors. And then the other is based on the location. So proton therapy can be particularly beneficial in patients that have their tumors in close proximity to the optic nerve. Those patients with brachytherapy, with other types of external radiation, they're at risk of having visual toxicities and even blindness from the treatment. But proton therapy, we can send the radiation in, we hit that target, and then we can spare the optic nerve. So those patients can really benefit well.
Right. Sounds like you can also spare the lens of the eye and prevent cataract formation, which would normally occur with X radiation.
We can. I don't want to oversell protons in that the lenses, as you know, are very, very sensitive to radiation. So even small amounts of radiation or scatter of radiation can cause cataract in the years after treatment. Fortunately, replacing or fixing a cataract is a lot easier than fixing a melanoma. So,
Right.
but yes, we can reduce the lens dose with protons relative to photons and have a reduced chance of cataract.
That's great. So, Dr. Lin, can you explain about the staff protection from the proton beams? It sounds like as long as you don't have a human between the source of the proton beam and the target tissue, they're not going to be exposed to any radiation. So if somebody's standing behind a patient, let's say a foot or 2 feet behind the patient, they shouldn't be exposed to any radiation. Is that correct?
Well, I think there's a misunderstanding. Typically, when we do the proton therapy, only patient is in the treatment room. The main reason is like definitely you don't get if you stand beyond the patient, and typically you don't get any proton irradiation. Like proton is totally absorbed and stopped in the patient. However, when the proton stop, it generates other particles like neutrons, which in the shielding of the treatment room is mainly designed for the neutron shielding itself. And neutron itself is not that easy to stop. That's why Dr. Simone mentioned there, there's the shieldings like high density concrete wall is like 3 meters or even thicker than that. Just try to stop the neutrons that outside of the staff member don't receive any unnecessary radiation.
See.
So on the other side, the different to like other radiation forms like brachytherapy, Dr. Simon mentioned, the external beam radiotherapy actually doesn't leave any residual radiation as soon as you turn off the beam. So that means like as soon as you like turn off the beam, you can enter the room and take a patient off the table, or you can reposition the patient there, and it's safe and go into the room. But on the other side, patient do get some activation, means that inside of patient body there are like carbons, oxygen, nitrogen, basically can get activated by the by the protons. However, those activation are pretty weak, and also the half-life time is like minute. So, that's why typically after the proton therapy, we can release the patient immediately, and they basically can interact with their family, kids. It's safe.
That's great. Yeah, because I have patients who've had radiation, the standard type with X-rays, and they're concerned that they might be radioactive for a while, and they're not. So it's kind of the same with protons. After about a minute, there's no harm from the patient. Is that right?
Yeah, that's correct.
Right. Now, you mentioned the neutrons. Where are these neutrons coming from? Is it from the source of the proton beam, or is it the neutrons in the patient's body are dislodged by the accelerated protons?
Yeah, when the proton actually stop, no matter it's during the radiotherapy or during the transportation, whenever proton actually stop, it basically generates secondary particle, and those secondary particle, some of the heavy particle are very easy to stop, and the most challenging one is the neutron because the neutron doesn't carry any voltage and it's not a charged particle, so it's very just like a ping pong ball, like bouncing around. That's why like you need a very thick wall to stop it.
Interesting. So the neutrons are coming actually from the tumor.
Uh, Basically, the proton actually release the energy and then release the energy and then knock the neutron out.
I see.
Yeah.
Now, tell us about the Bragg peak with proton radiation. Can you explain that?
Yeah, as Dr. Simone mentioned, the Bragg peak basically is the key characteristic of the protons, which make the proton clinical useful, clinical meaningful. The main reason is like, when there's a Bragg peak beyond that, there's a zero radiation. So the main reason for the Bragg peak is because we mentioned that the proton carries like high speed, like 60% of the speed of light. That means it's really fast. But when it enters the media, it interacts with electrons, nucleus through Coulomb interaction. But when it has a high speed, the interaction itself or the interaction rate is low because there's very little time that they can interact with the electrons or nucleus around it. But when it continues losing energy and then slow down, then the interaction will increase, especially at the very end of the trajectory of the protons, because the proton speed is so low, the interaction, rate increase significantly. So the proton actually deposit energy in very, very short range. That's why the dose build up pretty quickly and quickly drop the proton energy drop to zero and stop there. That's why there's a peak or spike at the very end of the proton trajectory, and we call it Bragg peak. It's named after Sir William Bragg. So he actually received the Nobel Prize
Really?
of physics in not in Bragg peak. It's in X-ray interaction with crystals itself. So it's basically a technology used to diagnose the different kind of crystal materials.
Right. Now, how many sessions of treatment are needed for the various cancers, or does it depend on the type of cancer and how large it is and where it's located?
Um, Basically, it's a same to the conventional therapy. So we basically adopt everything from conventional therapy and then um, explore everything. So the only difference is for proton, there's a biological effectiveness benefit. That means there's a 10% enhancement for the the killing cancer cell killing rate. So we actually model that in the TPS system. Prescription fractionation are quite similar. So typically, similar tumor, you don't see much difference if you're treating with photon versus proton for fractionation.
Right. Now, I've been seeing ads for years on TV about the CyberKnife treatment for prostate cancer, and the ads say you only need treatment for 5 to 7 days and then you're done. Is that the same for the proton beam for prostate cancer?
Yeah, that's one type of a hyperfractionated treatment. We typically call it the stereotactic body radiotherapy, SBRT. At New York Proton Center, we have around 10 to 13% of case treated with this short course or hyperfractionation. And typically the whole treatment course is 5 fraction or less. Either like every day or every other day. So that means 1 or 2 weeks you can complete your treatment.
Now, Dr. Simone, are the side effects from the proton beam less than the standard radiation? For example, with prostate cancer, the ads on TV say you can go back to your normal activities right away. Is that the same with proton beam, or is it even better with proton beam?
For most radiation, protons, photons, patients are, if they're working going into treatment, if they're going to the gym going into treatment, they're still doing those things, and we actually encourage that. The most common side effect of any type of radiation is fatigue, but patients seem to have less fatigue if they're more active. So we always encourage that. And yes, unlike surgery recovery or sometimes the day or two after chemo with nausea and things, generally patients tolerate radiation well acutely, and so we don't want them missing those activities, and we want them to stay active. Um, Both by treating less normal tissues and treating the normal tissues that we do treat to lower doses, we can see less side effects with proton therapy. Now, some tumors, again, we do very, very well with traditional radiation therapy, and the risk of toxicities are so low that even if there is a benefit with proton therapy, it's going to be a very marginal benefit. But by and large, two things. One is the side effects are less likely to happen with proton therapy. And two, if patients do get side effects, they're often, at least in the acute setting, less intense because those normal tissues are treated to a lower dose.
Right. Now, you've been doing this for years now. So, is there data to show that proton treatment has a higher success rate, for example, in mortality or morbidity of the various cancers? Or is it just reduction of side effects, but no real improvement in the survival rate from the cancer?
Great question. Everything that we've talked about today is kind of predicated on the physical properties of protons are pretty unique in that they stop, and if they stop, they can treat less normal tissues. But proton therapy really can have a survival benefit for several reasons. One, if you can have less side effects, you can intensify the dose or better cover the tumor, and so you can have an improved outcome in that way. A second is proton therapy we know is less immunosuppressive. We're treating less normal tissues, less lymph-producing tissues, and it may actually be data suggesting more immunostimulatory. And so in today's era where immunotherapy is, I'm sure you and this podcast viewers are very aware of, has really taken the oncology world by storm for a right reason. Proton therapy may be able to be more synergistic with immunotherapy in those patients. And then, as Haibo mentioned, there is actually a biological enhancement with proton therapy. So the same tumors that are sometimes called, quote, radioresistant, we actually, with proton therapy, because it has a higher linear energy transfer, essentially deposits more energy per path length in the tumor, they can actually have better killing of the tumor. And so some tumors that wouldn't have as high of a control rate can have a better control rate with the radiation with protons. So all that is a backdrop to say, yes, it's not just the toxicity and physical property, but there's a lot of neat biology of proton therapy as well that can improve outcomes. There have been several randomized trials started comparing proton therapy and photon therapy, which is a little interesting. You may have heard of, just like CyberKnife as a way to deliver intensity modulated radiation therapy, IMRT is kind of the modern term for regular radiation. That really has become the standard of care for curative treatments, even though we really don't have much, if any, randomized data showing a benefit over the older 1970s and 1980s radiation techniques. The proton community, though, has really wanted to prove the value of proton therapy. It's a limited resource, it's an expensive resource. So we really wanted to, just like we do at our center, if we're always pretty busy here and close to capacity, we really want to treat the patients that can benefit the most. So we've done a lot of work trying to understand which patients can benefit the most. And so several randomized trials have been conducted across many disease sites. And the first ones have just been reported. And several others have now completed accrual and will be reported in the next year or two, and a handful are still ongoing. Just this year, a big news, I guess, will be coming out in a publication, but already presented for oropharyngeal cancer, the most common type of head and neck cancer, one of the fastest growing cancers and most common cancers in the country. There's a big phase 3 multi-center randomized trial comparing proton therapy versus photon therapy. The trial was to look for an improvement in toxicity with proton therapy, and it did show that. Less toxicity, less need for feeding tubes, better quality of life, but it actually showed better survival as well. So again, if you can more
Right.
fully treat the tumor, if patients don't have failure to thrive after their treatment, they can do better. And so, we have randomized trials that have finished in several other disease sites that are all, maturing as we speak. For instance, lung cancer, the trial finished at the end of 2023 and will be reported within about a year to show potentially a survival benefit for locally advanced non-small cell lung cancer with proton therapy.
So what you're saying is there's definitely less side effects, and it seems like the studies are showing that there's a better survival rate. Why would anyone not want to have proton therapy instead of the traditional X-ray or photon therapy? Should every patient who is told that they need radiation get a second opinion from you?
Yeah, great question. And it's not every tumor for sure that will have a survival benefit. Just as I mentioned, some tumors we do great at with tumor control and outcomes. So, there won't be an appreciable difference with proton therapy. Some tumors, though, I think liver cancers, lung cancers, esophageal cancers, there's also randomized data showing a benefit for proton therapy over photons in esophageal cancer in patients with dissemination along the craniospinal axis. So several tumors that are very challenging to treat, proton therapy can be beneficial. If we look at all the patients that we treat with curative intent, most modeling studies, maybe that's an oversell. Some modeling studies suggest about a 20% of patients can have a really meaningful benefit to proton therapy. So it means 80% of people, they're going to do great with regular radiation. They don't need to leave their immediate neighborhood where they're convenient to get treated, where they may have relationships with their oncologist team. But for many patients, again, typically the tougher to treat tumors, the tumors with higher risks of side effects or lower risks of tumor control, and certainly for the recurrent tumors, for the pediatric tumors, those patients really can have meaningful benefits. And certainly any patient that ever has a question, they can ask their own oncologist about proton therapy. They can always call us and we can discuss if we think there could be a benefit to them.
Right. Now, you mentioned pediatric tumor. It's especially good for treating children. Can you tell us why that is?
Absolutely. So our little ones, they're still developing, and so they're very susceptible to having side effects from radiation therapy, including neurocognitive side effects. One of the most common presentations of cancer in children are brain tumors, unfortunately. Radiating the brain at a very young age can be associated not just with short-term memory changes or neurocognitive changes like we see in adults, but actual IQ loss and real functional loss in little children who have developing brains. Uh, so just like with the brain, any part of the body that's still developing, we really want to protect those children and minimize side effects. The other side of it is we fortunately have done tremendously in the last many decades of improving outcomes for many of our pediatric tumors. So these patients are living now decades with what can be long-term complications from radiation therapy, one of which can be a secondary cancer induced from the radiation itself. Very rare, but it's more likely to happen in people that, one, live a long time, decades, like a pediatric cancer patient would. And so anything we can do to mitigate long-term side effects in these patients, including secondary cancers, is critical. And we know that proton therapy, by treating less normal tissues, can help to prevent these secondary cancers. And there's a good amount of data showing that as well.
Can you treat eye retinoblastoma, which typically happens in young kids with proton?
We do, yes. The most common tumors that we see in kids are the primary brain tumors, the abdominal tumors, the Wilms tumors, the neuroblastomas, and then other types of sarcomas or lymphomas. But certainly, the rhabdosarcoma that originates in the eye, it's something we certainly see here, and really those patients can benefit a lot and potentially spare them from having long-term blindness.
That's great. Now, you mentioned earlier this is FDA approved now for years, right? The proton treatment.
Correct, approved in 1988 in the US.
That's great. Is it covered by Medicare and other private insurance companies?
Yeah, so Medicare almost universally covers proton therapy for cancer diagnoses. Almost every solid malignancy, probably 98, 99% of cancers that we would treat in the clinic, Medicare is determined, and through a review of the literature, the proton therapy is not considered experimental. It's a standard treatment approach, and in many cases can be an optimal treatment approach. Insurance companies, private carriers are a little slower to adopt new literature. So, for instance, we do a randomized trial that started, say, 10 years ago. It takes 8 or 10 years to get the data, and then a couple more years after the data is presented for the insurance company to want to change their policy to say, yes, proton therapy actually benefited this population. But majority of patients that are requested for insurance do get approved nationwide. Here, it's 9 out of 10 that have a private insurance that are requested proton therapy do get approved. So large majority will ultimately get approved. Doesn't mean there may not be delays in getting them approved. We've done a lot to try to work on taking those delays away, because the last thing we want is for a patient with cancer who we really know can benefit from protons to have to wait on getting their treatment. So we've done things to help expedite their care. But the large majority of insurances do include the large majority of cancers for sure.
Do the insurance companies ever say, oh, you could just have the standard radiation therapy, you don't need proton treatment?
It can happen, sure. So different companies have different policies. Some policies say that protons are quote, experimental for certain disease sites, whereas they're standard of care for other disease sites. Even when it's considered experimental, which we could argue if it's almost 40 years FDA approved and we have great data in many disease sites, but it's a way to contain cost, I think, for the insurance companies largely. But even the majority of those patients will ultimately get approved, but it could take time to get approved through appeals and other things.
Right. Now, tell us where the New York Proton Center is located and which specific hospitals you're affiliated with.
Absolutely. So we're here in Manhattan in New York City. We're in Harlem on the east side. We're at 126 between 2nd and 3rd Avenue. So the entire building really just for proton therapy, and we take up a city block by a good half of an avenue here in New York. We are co-owned by Memorial Sloan Kettering, Mount Sinai, and Montefiore. So those are the 3 main hospital affiliated partners. We certainly service the entire state of New York. So we regularly work with and partner with, practices and hospitals from all over the state. And we really have patients from all over the country and world that come as well. But those are our 3 hospital partners that we work closely with.
So if a patient happens to be at Cornell or Presbyterian, Columbia Presbyterian, they can still come to the Proton Center and get treatment, right?
Absolutely. And we do regularly treat patients from both of those institutions that you mentioned. We work closely with the oncologist there. We have shared patients where they may get the chemotherapy, the immunotherapy, or the surgery at those institutions, but they come here to help to try to reduce the side effects with the proton therapy.
That's great. So how many years did it take to build this massive building with this massive equipment, and what did it cost?
Yeah, good question. So it took about 10 years of planning. In that time, it was the New York is a certificate of need state, so you need to actually have a certificate applied to be able to open a new proton or any type of radiation facility for that matter. So it was many years of working together in partnership to form a coalition. And this is really pretty unique in all of oncology and really all of medicine to have what was otherwise three relatively large competitors who are each of themselves world-class institutions come together for one shared vision of being able to bring proton therapy to New York for the first time. So, getting the coalition, getting the certificates, developing an area where the construction would occur. This was not the first place that we looked. There were a lot of land zoning laws and other things, putting the cyclotron in Manhattan and otherwise. So, took about 10 years to get us to this point, including about the last 2 years for construction. And then we've been open, as you heard, for almost 6 years now. July of 2019 is when we opened. So 5.5, 6 years we've been open at this point.
Great. And what did it cost to put this all together?
Yeah, so in total, on the order of about $300 million for the facility. About 60 million of that is just for the actual hardware equipment for the proton therapy. Many tens of millions for construction for cement and other things to insulate the facility. And then, of course, in Manhattan, building costs of more than $100 million. This is a pretty large facility. In total, it's about almost 140,000 square feet. It's the largest freestanding proton center in the United States.
Really? Wow.
Smaller centers, obviously smaller footprint, maybe one single treatment room, a much cheaper footprint. We really, knowing that this would be the only proton center in the state for the conceivable future, and obviously the biggest city in the country here, needing access to this potentially life-saving modality, we made a relatively big center. We have 4 treatment rooms as well as a dedicated room for research. So a relatively large facility and large costs with it as well.
Oh, that's amazing. Are there any proton centers in adjacent states like New Jersey, Connecticut?
Yeah, great question. So not in Connecticut, although there will in the future be up to 2 proton centers in Connecticut. Both certificates of need have been accepted by the Department of Health in Connecticut to build. They're still probably years away for both of them, but ultimately will be. The closest one north of us otherwise has been in Boston at Massachusetts General Hospital. They're one of the first proton centers in the world, and so we kind of filled the void of anything south of them after we opened. New Jersey also has proton centers. The closest one to us is kind of mid-north New Jersey in the New Brunswick, Somerset areas.
I see. That's great that we have a terrific facility like that here for patients.
Yes, we're very lucky.
So this has been very informative and educational for me, and I'm sure the audience out there as well will appreciate learning about this and that there are newer and often better options for treating cancer. So I want to thank you, Dr. Lin and Dr. Simone, again for taking the time to join us today to educate the public about this very important matter.
Our pleasure. Thank you so much for having us.
Yeah, thank you. Our pleasure.